Welcome to another episode of the Federal Newswire's Business of America podcast with your host, Jerry Rogers.
Welcome to another edition of the Business of America. We are focusing on healthcare again because it matters, because it's nuanced, because it impacts industries from small businesses to big pharma. It matters for patients, for science, and we've had our guest on before. She might be the first returning guest, Kirsten Axelsen. And I'm going to let AEI, I know you from AEI, but I know that you have a long bio of important things that you do. So why don't you tell, Kirsten, tell our audience what you do, where you do it, and even why you do it.
Thank you so much. So I have worked within and for the biopharmaceutical industry for the last 24 years. I worked at a large biopharmaceutical company for 19 of them. Now I am a non-resident fellow with the American Enterprise Institute, as well as a consultant. I'm a senior policy advisor affiliated with DLA Piper. I work in the biopharmaceutical industry because I, like all of us, appreciate the value of medicine in terms of our longevity and health. But also, I believe that competitive forces and market-based incentives are the right way to encourage development in transformational cures. There are flaws in the system, but personally, I would rather see the epidemiology of disease and the private market driving where investment goes and what diseases are studied rather than political or emotional decisions. I just think of what the world would look like if political decisions had driven the diseases that were studied over the last 50 years rather than unmet need and population size and ability to get the drug paid for.
And the politics involved in that and the narratives, misinformation, false narratives in terms of healthcare policy. What I want to do today is set the record straight as best we can on a program that many people might not know of by name, but their families or their hospitals, the price they pay for medicines is impacted by this program, and that is the 340B program. And again, we're not going to be wonkish here on the Business of America. This matters because it matters in terms of underserved communities. It matters because of drug prices, which is still polling at top of the list in terms of this election cycle. People care about the cost of medicine, the cost of healthcare, access to healthcare. And 340B plays right in the middle of that. I have some specific questions that I want cleared up, or I need to better wrap my head around, and our audience. But could you give an overview of 340B? What was its intent? What are the programs or the program? Who are the entities? Just kind of a 30,000 foot level 340B synopsis.
Sure, thank you. So the 340B program was designed and I believe is intended to help hospitals that serve disproportionately large numbers of higher need people. Hospitals are defined based on a formulary in the law, based on the types of people they serve, in particular people who are in Medicaid, which is typically for lower income people and disabled people. Those hospitals are able to purchase drugs at deeply discounted prices and receive whatever price the beneficiary's insurance pays them for that drug. So if you are being seen at a 340B hospital or 340B affiliated hospital, which you might not even know you're being seen at a 340B affiliated hospital, you don't necessarily have to be on Medicaid. You don't necessarily have to be uninsured. Your hospital is purchasing that drug at a deeply discounted price up to, it's estimated that discounts are between 50 and 70%. And then they're getting reimbursed whatever your insurance is. So if you go in with good insurance and they've negotiated a 15% discount, the hospital keeps the difference between that 85% of the price and the let's say 25% of the price they're paying. So this helps funnel money to hospitals that are treating high-need people. It is important to get money to hospitals that are treating high-need people. However, probably even just in listening to the description of it, any business owner or any person who understands financial incentives would say, wait a second, that creates a problem because it creates an incentive to use the most expensive drugs in the most well-insured people. So what we've seen is a big expansion of hospitals, in particular purchasing provider groups who treat oncology patients, expensive drugs. You can get a very well-reimbursed drug and purchase it at a very low price. If this money were going back into patient care, if this money were going to relieve medical debt for low-income people, maybe it would be a fine system, but it's not. Some of these hospitals are using this money for low-income care, but they are not required to. They are not required to establish that the person who's receiving the drug is a low-income or high-need person. So that's just a bit of an overview of the program and some of the initial misaligned incentives.
So, again, what caught my eye on this, some time ago, there was a New York Times piece talking about how the entities participating in 340B were investing or engaging in low-income neighborhoods and diverting the savings back to their more wealthy areas or wealthy patients. So you said that it's meant to, the intention here is righteous, to help the underserved, to bring greater access to medicine and care, but without the requirement to help those who need the help. Are there opportunities? Abuse is a strong word, but to game the system so it betters it betters the hospital, the administration, its bottom line, as opposed to helping patients.
Absolutely. And, regardless of whether the money is going to help patients or not, when you think about the incentives, the structure that's set up, the way the hospital can maximize the benefit from this program is to go into higher income neighborhoods and acquire practices that dispense expensive drugs. So that increases their use of expensive drugs. It increases consolidation by purchasing these practices. You see more provider consolidation. So possibly some of that money is going back into patient care. We know it's not all going back into patient care. But regardless, that's not the right way to get these hospitals funding for serving low-income people. There are changes that could be made to the program that would, for example, direct the funds to low-income people. But I would argue funding hospitals based on the arbitrage opportunity in a drug price is not the right way to do it. And I would rather see the program designed entirely differently. If we think that low-income hospitals should be financed on the backs of drug companies, there are different ways to do it that are unconnected to the price of the drug. But most importantly, this money should be funneled to patient care, in particular to patient care for low-income people, and reducing their expenses or their financial liability if they are unable to pay their bills.
Now, in Washington, D.C., and I know you are obviously engaged in health policy. I'm the editor at Real Clear Health, Real Clear Policy. I'm engaged in healthcare policy. There seems to be consensus, and this is odd in D.C., especially during an election cycle, that 340B needs reform. And there are various reform proposals. Some are narrow, some are broad. Let me ask you this. We won't get into specifics in terms of endorsing this proposal or that proposal, but it does seem that patient organizations, biotech firms, as well as big pharma firms, the physician advocates and others are keen on reform. The Hospital Association, the American Hospital Association, and those interests are more opposed. But if you look at the kind of the various partners and stakeholders in healthcare, there seems to be a consensus that reform is necessary. Let me ask you this, just to stay on the pharmaceutical companies for a second. There are companies that take, and very few companies, they take 50, 60, 70% of their profit and reinvest into research, into innovation. How does 340B impact companies, bio companies or pharma companies that are taking a large percentage of their profit and reinvesting it into innovation? Does 340B in any way have a negative impact on science, on research, on, you said as we started here, and I loved it, on cures, right? On the cure for the cancer, the disease, the pandemic that hasn't even presented itself yet. Does 340B impact innovation at all?
So 340B is now the second largest program in the United States after Medicare. And we know based on prior studies that the Medicare program affects the direction of investment in clinical studies. So, and that was in a positive way. When Medicare Part D was passed, we saw more effort shift towards clinical studies for therapeutics that principally treated older people. The 340B program, by reducing the size of the market, does have the potential to reduce investment in clinical study. The other thing the 340B program is likely doing is raising launch prices insofar as the market can tolerate it. Launch prices means the initial price the drug is set at before other discounts are offered. That affects the out-of-pocket costs for people who have coinsurance or people who are not insured. So it definitely has a distorting effect on both pricing and clinical development decisions.
So there's lots of talk always in healthcare, in the business of healthcare, transparency, whether it's surprise medical billing or hospital prices or prices for care. I hear the word transparency connected to the 340B program. What would transparency look like in a reformed 340B?
The program is so huge and has such limited oversight and such limited.
There's no transparency whatsoever.
Exactly. In the current structure, there can be transparency. There's not enough people. Not enough time, right? So yes, I think transparency would help, but putting different guardrails around the program, or even reforming the program so the money is not made off of the arbitrage in the drug price, to me is a better solution than simply transparency. Transparency is sort of a stopgap measure if we can't get to a better place in the policy. But transparency is only useful if there's somebody looking at the transparent data, and right now no one is looking at the transparent data. In fact, the Inflation Reduction Act will allow 340B facilities to it will require pharma companies to provide the lower of the price setting from the federal government in Medicare,
right,
or the 340B facility. CMS has already said they're not going to monitor for duplicate discounts. We already know there's duplicate discounts with Medicaid, which is already not allowed. That this basically means that the 340B facility is getting both the Medicaid rebate and purchasing a low-cost drug. So we've just created another opportunity for fraud and abuse of this program. But the government said we don't have the time. We don't have the ability. So I would say I'm not sure transparency is enough. Rather, sensible reforms to the program that would either limit the patient population so that it's only going to people who have high needs, such as the uninsured, or other guardrails like that keep the program from just mushrooming as it has. So
again, in Washington, D.C., if you are engaged in the policy, especially health policy, you hear these words all the time: waste, fraud, and abuse, transparency, and the patient-centered care. And it's becoming disheartening because they're throwaway lines now. A member of Congress wants to put out a newsletter to her constituents, and will throw in there, and we're dealing with waste, fraud, and abuse in Medicare to make Medicare stronger. Medicare, how is Medicare impacted by 340B? Medicare Part D in particular, but I guess what is the oncology part of Medicare? Is that Part B? So does 340B have an impact on access to cancer care?
So cancer medications can be Part B or can be Part D drugs. Part B means they are administered by a physician, typically in their office. So it would be like an infusion for cancer or an immunosuppressant. Part D typically means the person picks the drugs up in a pharmacy and uses it themselves, either a pill or a self-injection. Some of the ways that this program likely is affecting Medicare is with higher launch prices. And again, in Medicare, many people are subject to co-insurance or a deductible.
Can we stop there real quick? Because I want to make sure our viewers get this. So when you have this essentially artificial intervention in a market, and as a company, right, the business of America, many of these healthcare businesses need to make a profit so they can come up with new medicines, or they need to pay their physicians and nurses. There is a profit here. So if you interfere in this market with these discounts, if I'm the CEO of a company or the board, I'm going to say, look, we could launch this at X price, but we know we're going to get dinged. So therefore, let's launch it at X plus whatever. And again, this impacts not only access to medicines, but the overall the cost of medicine, the cost of healthcare. Is there a way? Well, again, I mean, I don't want to get into it, but how do you? All right, here it is. You got to fix it right now. Is there a way to fix that? And so therefore, these discounts are going to the right people. I guess here's my question, right? I'm thinking out loud here. I'm an Irish guy who thinks out loud. I talk to think. Should 340B be done away with, or should it be fixed? Is it fixable?
I think it needs to be fixed.
Okay.
These hospitals rely on the funding to help people who really either don't have the finances or have health conditions that are sufficiently costly that it is, it is a financial challenge. So the funding to the hospitals, in my opinion, needs to be sustained. What the right levels are, I'm not the person to ask that. I think the mechanism for funding is deeply flawed. If I were in charge of the world, it would not be connected to drug prices. Wouldn't necessarily need to all come from drug companies. But that's, clearly I have worked for the biopharmaceutical industry for 24 years. I also happen to like fewer people dying of heart attacks. I'd like to see innovation in medicine and a number of other diseases. I think the program needs to be reformed. There are ways you can do it either by, in addition to changing the connection of the drug price, by requiring the money goes to certain types of patients who have the high need, to lowering copays and co-insurance. So I think the program has the ability to be reformed. But I would say those reforms should go farther than just transparency if we want to actually make a meaningful difference in the program, in particular because there are not enough people to read the transparency or the transparency.
Well, let me ask you this, because I think you're 100% correct. It needs to be reformed. It needs to be fixed. But again, there are several different proposals in the Congress right now. Some are narrow, some are broad. I would say that I'm gonna make a statement, and then you tell me if you agree or disagree or expound on it, or say, Jerry, please don't make statements like that ever again. I think that we shouldn't be arguing over the broad scope or the narrow scope. I think that there's a loaf of bread, so to speak. And if we can get a slice of reform, I would take 2 slices that make it better, even if the program itself still needs fixing. I think some reform, incremental reform, is doable, and I think we should go forward there. But there are some who say, no, it needs to be broad reform. It needs to be now. What's your view on that in terms of the is a slice here, a slice there? Is that good or good enough, or do we need wholesale comprehensive reform and not the incremental reform?
I think chipping away at the edges is the best we can hope for in today's political environment, and that's better than nothing.
Good. So my statement wasn't my statement wasn't wackadoo, as my father would say. Hey, kid, that's wackadoo. How does this public discussion, the discussion over 340B, does it have any kind of connection to when we talk about other issues like transparency in pricing, or in the price setting in the IRA, the Inflation Reduction Act, or in myriad other issues? Is this just a sliver, or is this part of a part of a whole where we need to be looking at reform in all these areas when it comes to drug pricing, transparency in prices, innovation, and these sorts of things?
I mean, as it relates to drug pricing and drug pricing transparency, for the majority of drugs, the listed price, so it's like the sticker price, I shouldn't say for the majority of drugs, for drugs with competition, where there's multiple drugs in the class, very often that price that you see when you hear the $10,000 pill,
yes,
or whatever the number is,
yes,
is not what the price ends up being to the insurer. And so some of those are privately negotiated discounts, and some of those are federally mandated discounts like 340B, like Medicaid. Even within the current Medicare program, before the federal intervention on pricing occurs, there are discounts required in different portions of the benefit. So part of why we have such a complex pricing system is regulation. Part of it is the way the market has been working. And that's hard, because back when there was mostly 3-tiered formularies and you paid a copay, it was a fixed dollar amount. It didn't really matter to most people what the price of their drug was unless they didn't have insurance. No one can afford to get healthcare without insurance. Very few people in this country can. So whether the drug is $10,000 or $2,000, that's still a problem. And when people go after drug pricing as a way to solve the uninsured problem, I think, well, who's going to pay for their doctor? Who's going to pay for the hospital? An uninsured person does not have the ability to access care affordably, including their drugs. So I think drug pricing transparency and the uninsured are not good problems to link up. That's a problem that needs to be solved and cannot be solved on the backs of drug pricing.
So not connected to 340B, but something that we hear a lot, and that is, look, companies do good and bad things. America is blessed. We have a thriving, innovative biopharma sector in this country. And again, the best in the world. However, they are often the target of both Republicans and Democrats, where I mean, I've heard Donald Trump bash the pharma companies. I've heard Ms. Vice President Harris bash the pharma companies. And again, this is a little bit of commentary I'm asking for you. But why is that? Why are our elected officials, the men and women who we trust in public office, why do they attack and make a political scapegoat out of? Maybe this is a naive question. Why do they go after big pharma as opposed to promoting pharma, especially in terms of its kind of American footprint?
I mean, I'll speculate. I think a lot of it is emotional. People know their local hospital. There's local hospitals in a lot of congressional districts.
That's a brilliant point. Yes. I'm sorry. Continue.
They know their doctors. You go to the doctor, even if he doesn't solve the problem, you have a relationship there. Typically, you leave feeling good. The copay for a doctor visit is far or less as a percentage of total cost. If you are in truly dire straits, you go to a hospital, you get the care. You may end up in medical bankruptcy, but you don't have to pay before they admit you into the ER. Whereas a drug, either people can't afford it or they don't like it. And I would include myself in that camp. No one likes to go to the pharmacy and pay for a pill that might not make you instantly feel better, or might just make you keep feeling the same and not have your condition worsen. I don't think you get the same kind of satisfaction. I won't say that for all conditions. There are conditions where the pills are curative. There are many conditions where cancer treatment has turned deadly diseases into chronic diseases. But paying for a pill doesn't feel good. And sometimes it's impossible for people. So I think a lot of it is that emotional connection. The final point I'll make with drugs and drug companies is they are very easy to villainize because the successful ones are wildly profitable. The unsuccessful ones are not. And the unsuccessful ones we don't see. And billions of dollars are poured into the unsuccessful ones, and they never make any money. So the drug companies that are out there are the ones who have done well, and their profit margins are big, And that is what sustains investment in these little companies that are probably going to fail, and the academic centers where most of the inventions are probably going to fail because of the anticipation that someday they might be acquired by one of these big profitable drug companies.
You know, it's interesting, your point about the emotional connection, almost like the neighborhood connection. You know, I've done some work with veterans groups in healthcare, but in other areas. And I'm always curious, why did you join? Why did you volunteer? Whether, you know, for me, you know, kind of post 9/11, many men and women signed up because if they felt it was their duty. And I'd ask these questions, why? And, you know, they give the broad, because I love my country, because we were attacked. But the answer that always comes back from everybody, regardless of if it's a New Yorker or if it's someone from a rural Ohio town, it's I want to protect my neighbors. I want to protect my hometown. I want to protect my neighborhood. Neighborhood is a word that kept on coming up. And I think you hit on something here. When it comes to healthcare, you know, you support your neighborhood. So like for us in my house, I have 5 children. It was the nurses who took care of my wife when she was pregnant. And even now, it's the nurse practitioners who really do the bulk of the work when my kids go for checkups or they're sick, and they're the ones who call. I still have a medical practice where they call us. Hey, Liam was in. How's he doing? And we know their name. Like, we know their name. And so this is interesting because in the 340B fight, public discussion, I don't like to use the word fight, in the public discussion over 340B, there is a lot of, we need to fix this. And I've asked folks, well, why isn't reform happening more quickly? And it comes back because, well, broadly, it comes back because usually the hospitals are a large employer in the congressman's district. And he knows the players at the hospital. But you're right, the pharma companies, the ones that we hear about, are so large and so diverse in terms of where they are. You don't get that neighborhood feel. So my question is, after that long statement, is there a way for pharma, for biopharma, for bio companies in particular? Because I've interviewed some bio companies on this program and the work they're doing in the rare disease, orphan disease space. It's phenomenal. I had one guest, I started to cry during the interview, and I sustained, so I couldn't even cut it out when we posted it. The work that some of these biotech firms are doing, is there a way, is there a strategy for them to be part of the neighborhood as opposed to just this big entity that makes lots of money?
That's a good question.
If we can figure this out, you and I could open up a consulting firm, make a lot of money, right?
I wish I could. We definitely affiliate our warmth for those scientists with the academic institutions, with small biotech companies. But let's be clear, academic institutions make a lot of money off of drug patents.
Yes.
And so, for example, when we're talking about exercising march-in rights to get lower prices for the governments, you're talking about taking the patents away from academic institutions for a large part of it, who are getting money from the drug companies who have purchased the rights. So I don't know how to better make that connection, but there is no small pharma without big pharma. There is no funding to academic centers without the anticipation that some of those programs are going to be profitable. It's a very, very, very high-risk business. And that means that, like any gamble, you have to do really well sometimes to offset the times that you really don't do well. And for us, doing really well means there's curative therapies for rare disease. There's finally a bunch of drugs that can help people lose weight who've been struggling with it forever.
Yes.
There's treatments for diabetes.
Now, with the losing weight, did you look at me and say, "Oh, Jerry, come on now, there's medicine for you now"? But you're absolutely right. It's very curious to me. But Billy Tozen, the former CEO of pharma back in the early 2000s, and of course he was a congressman, once a Democrat, then a Republican congressman from Louisiana. he said something once that made a lot of sense to me. He said, look, he said, we're not, again, it might sound silly to some, but he said, we're not making ice cream. Like, we're making something that means life or death in some instances, but it also means better living and longevity in other instances. And, and he almost lost his life with some issues that he had, and it was a medicine that saved his life. And so he became a true believer in terms of the innovation and what it means. Maybe that's what we need to do, or what pharma needs to do, is narrative, tell the story. I talk to organizations that go up to the Hill and they want to move their congressman on an issue. And they have lots of stats. They have lots of numbers. And, the cliche is no one cares what you know until they know that you care. And so therefore, when you're talking to your member of Congress or to their staff, tell them your story. Don't tell them the numbers and the data. Send that to them, but tell them your story. And maybe we should do that here on The Business of America. Start telling the stories of these companies and these entrepreneurs and these scientists who really are doing great work, new cures. I know you've been on the program before. The point here, the ethos here, is the man, the woman in the arena, doing good, the doers of the economy, and pay no mind to the critic, although it's hard to do that. But our concern here is the doers. And if you certainly fit in that camp in terms of the great work that you're doing. And I know that our listeners and our viewers are aware of your work, but we'll make sure that it's linked here. But before we leave, any closing thoughts in terms of this issue, but healthcare broadly? You mentioned March-in rights. I wouldn't mind, before you sign off, and let us just tell our viewers again, remind our viewers what the March-in rights issue is.
March-in rights, there's a good number of drugs that had federal funding in their clinical development programs early on, often grants to academic centers. There are very few drugs, actually, almost no drugs that were developed entirely with federal government funding. March-in rights were put in place to allow the federal government to allow others to manufacture a patented drug if that drug company is not meeting its obligations to supply the necessary amount for a population, if the government has invested, and there's a threshold into their clinical development programs. March-in rights have never been exercised, even though the NIH has been asked to exercise them multiple times, because the directors have said, no, there's sufficient supply. I understand you don't like the price, but there's sufficient supply. And people are, hundreds and thousands of people are getting the drug, which means somehow it's being affordably accessed. It doesn't mean it's being affordably accessed to every person. March-in rights would essentially make collaborations with academic centers way riskier, way less valuable, and I would even say toxic.
Threatening the neighborhood.
Threatening the neighborhood. I would also say that would be done at a time when other countries, in particular China, are doing a really good job at building up their capacity to do early R&D. So it's not like there aren't other places to go for it. So I think it would be a huge threat to not only medical innovation, but to academic centers in the United States.
I mean this very seriously, could sit here and talk with you all day. I think you're brilliant. I think your insights they matter. I think you have a way of taking something complex and making it more conversational so our viewers can understand it. And again, this is the ethos of this program is to talk about the doers, talk about those who are making a difference in the arena. And so, Kirsten, I thank you so much for joining us. Before I let you go, though, is there anything you're working on? Is there anything closing that I missed that you want to touch on? Or you could just say, Jerry, go get those weight loss drugs, and I'll see you next time. but I'll give you the last word.
Thank you, Jerry. I am doing a lot of work right now, in particular on monitoring the effects of the Inflation Reduction Act on investment.
That's our next show. You'll be the only guest to return 3 times, and I want to talk about the IRA.
I'd be delighted. Please have me back. Thank you so much.
Thank you so much, and have a wonderful rest of your day. And you can find Kirsten's work everywhere, but especially at Real Clear Policy and Real Clear Health. So anyway, thank you so much. This has been another if I don't say so myself. I don't know who I'm talking to, the studio audience. Great episode of The Business of America. We'll see you next time. Thank you.
This has been the Federal Newswire's Business of America podcast, hosted by Jerry Rogers. Check out the Federal Newswire's family of websites, as well as their social media stream